Good morning, everyone. Thank you all for joining us today. I'm showing the top of the hour here, so we'll go ahead and get started. Let me see here. Caleb, you got the slides. Mr. Jeff, we're good. Okay. Welcome everyone. My name is Nick McRae. I'm one of the program specialists here with the Delta Regional Community Health Systems Development Program. Accompanying me today is my always incredible to work with colleagues, Mr. Caleb, Denise, and Shannon Sorry. We have the pleasure of presenting with you and Mr. Jeff Summer, the Qualifying Rural Value as part of the financial webinar series today. So thank you all for being with us. Next slide, please. Okay, and the purpose of the financial webinar series today is for us to really bring some industry best practice and knowledge related to this qualifying rural value and attempt to help you gain a better understanding of this that will ultimately help improve your organization. And certainly none of this would be possible without the support from the Delta Regional Authority, HRSA, and the Federal Office of Rural Health Policy for making all of this an opportunity for us today. So very grateful for that. All of you know, it being part of the Delta, that the National Rural Health Resource Center is committed to diversity, equity, inclusion, and anti-racism, both in our organizations and those that we support. To find out additional resources, please visit our website to assist your organization with that commitment as well. And with that being said, I will pass the torch to Mr. Caleb Lazinski and Mr. Jeff Summer.
Thanks, Nick. I really appreciate it. So as I introduce Jeff today, I want to pull up our pre-polling questions that we have for evaluation purposes. Feel free to fill that out at your leisure here. So Jeff is Stroudwater's affiliation and partnership. He was the leader for Stroudwater's affiliation and partnership in capital planning and access service lines. For 25 years, he has focused on assisting clients with strategic initiatives, including planning and executing major capital projects, analyzing strategic operations, crafting of innovation affiliations, and executing business development opportunities. Jeff, we are so excited to have you here today. I will stop sharing and allow you to take over.
Great. Thank you, Caleb, and thank you, Nick, very much. Happy to be here with you all. Just allow me a minute or two to get my slides in order. Has my share screen been successful?
Yep, you shared your screen, Jeff. And I think you're transitioning here to presentation mode. And then, we are seeing the
your notes.
Presentation slides.
There we go.
Yes,
there
perfect.
We go. Perfect.
Thank you, Jeff.
All right. Thank you. I'm glad we got through the technical piece. It's always a bit of, you never quite know how I'm going to get us where we need to be. So, well, again, welcome and thank you for your time. This slide presentation is kind of a reflection on our experience helping rural health systems around the country navigate how to create or modify existing relationships so they're sustainable win-win relationships, and really wanted to speak to some of the challenges and opportunities of that journey on behalf of our clients. Nice picture of me when I had more hair. Won't bore you with that. Part of the premise or the insight here, I don't know how many of you have either seen the movie Moneyball or read the book by Michael Lewis. It's a book about baseball, and it's a book about how the powers that be, the key folks who evaluated talent in baseball got it wrong at one point. And the Oakland A's were a small market team with a small budget and needed to figure out a way to they could compete against big market teams with big payrolls like the Red Sox and the Yankees. And their GM, using some very insightful analytics, tools and folks that had developed the skill set came to believe and demonstrate that the powers that be were undervaluing certain skill sets. And in this case, on-base percentage versus being a slugger. And on-base percentage was a better predictor of wins and was not correlated with salary. And what the Oakland A's were able to do was build winning rosters, even with the constraint of being a small market team, because there was this misallocation or undervaluation of a particular subset of the market. And what we believe is that something similar is happening in healthcare today, where folks are applying a broad brush to rural and frankly don't understand the intrinsic value proposition of rural health systems in today's environment. So is something happening like this in healthcare? Our experience says yes. We've worked with existing systems. These are large, sophisticated systems that have significant rural operations. And because they have either not taken advantage of certain designations or aligned those rural health clinics under the wrong organization, they're receiving 8 figures less compensation, reimbursement, payment annually than they could have. We've worked again with another large system that has significant rural operations that has undervalued the incremental referrals from rural affiliates because they've been assigning a too high a proportion of variable cost to each incremental referral. And in our experience, a 20% variable cost for incremental referrals is more realistic than in this case. I think they were approaching an 80% variable cost assumption, which significantly undervalues an incremental referral from a rural affiliate. One result of this is that rural health systems have too few or unattractive partnering options, or the terms and decisions of an existing partnership are being made with imperfect information and a flawed understanding of what that value proposition is. So again, some examples of this: initial skepticism of a potential partner replaced by awareness and excitement about the value proposition that a rural affiliate could bring to them. We had another client that had an initial LOI, stands for letter of intent. It's one of those affiliation terms, but had an initial letter of intent that really was incredibly unfavorable and had some very flawed terms, replaced by a letter of intent that actually reflected the value proposition: significant investment commitments, service commitments, and governance role of the local affiliate once there'd been an opportunity to kind of educate and inform. So the assumptions that people are bringing to the table around existing partnerships and potential partnerships are flawed. And we see this happen time and time again. And it's really important that rural health systems understand their value and that they document it and communicate it to existing and potential partners. So the reason this matters, as many of you probably already understand, is if you get this wrong and you significantly undervalue your rural operations, you'll underinvest in them. You may even divest of them. And the result of that is access to healthcare and the provision of healthcare in rural markets is compromised. If a partner does not value incremental referrals and underinvests in rural affiliates, they could have significant leakage of attributed lives for the parent system. And you end up having this breakdown of systems of care, clinical referral relationships, et cetera. Failure to capitalize on opportunities. And the partnership terms, frankly, not representing the value that a rural affiliate can bring to a system. So those are all really key concerns and issues that we've spent a good deal of time trying to address and correct. And it really, in our estimation, shows that not in every case, but frankly, in a lot of cases, there is this fundamental undervaluing or misunderstanding of the fundamental value proposition of a rural health system. So webinar objectives, we want to make sure that rural health systems understand their unique attributes and value proposition, so they can engage successfully with existing partners or prospective partners around that value proposition, which then informs the terms and investment decisions, et cetera. We want to outline what those value drivers are, so that, again, those conversations can occur. We also want to provide a framework, whether it's an existing partnership or a prospective partnership, on how organizations can best realize and create those sustainable win-win affiliations. I will just say philosophically, any kind of partnership, if you go in with the mindset, we're going to take the lion's share or all of the value, that typically is not successful in the long term. It has to be a win-win on both sides. But all too often what we've seen is, because the rural health system may not be able to articulate and communicate its value, and certainly the partner or prospective partner or current partner across the table doesn't have the expertise or insight to understand the nuances of cost-based reimbursement or cost reports or rural health clinics or swing bed programs, all of those things. And it really is important to have that dialogue. And again, it's really important to have a process and structures that will allow you to realize that. So there's a lot there, and a lot of potential value that's being either under-realized or not realized at all currently. And all of this is occurring within an industry context that is extremely challenging. You can see here the rating agencies, in this case Fitch and S&P, which stands for Standard & Poor's. They do annual and actually twice a year outlooks for the not-for-profit healthcare sector. And it's a challenging time. And we've gone from negative outlook and associated with the disruptions of the pandemic to some cautious optimism related to COVID relief funding, to now some very concerned outlook about the underlying margin pressures of cost escalation, labor, supply, pharmaceutical costs really increasing far more rapidly than payment is. And so while a lot of health systems, by virtue of PPP or CARES Act funding or various other provisions, have enhanced liquidity at this point in time, it's really important to realize the fundamentals and the cash flow run rate for most organizations is going to be very challenging going forward. So we have a moment in time where, again, if you're in a partnership, you've got some liquidity. If you're not in a partnership, you've got some liquidity. It's important to take advantage of that and make sure that you're doing the fundamental things and looking at operating performance to address those challenges going forward, because those cash and reserves that sit now as a result of COVID relief and other funding mechanisms, that's a one-time benefit. It's not going to be recurring, and there's some real challenges coming down the pike. So the market has not remained static. It's continued to evolve. And some of these fundamentals are that insurance premiums are for a family over $20,000 per the Kaiser Family Foundation annually. And oftentimes that's associated with a higher or a high deductible health plan type product. Technology and telehealth have shifted how people are accessing health systems and where they're receiving services. Hospital inpatient long-term trend, volumes declining, but what's relatively new is hospital outpatient volumes declining. So while the overall utilization of outpatient services and demand for outpatient services is increasing, the portion of that delivered by hospitals has resulted in falling outpatient volumes in some instances, and as an overall trend for the first time in recent years. So the feds, with all this in the background, have said we don't want fee-for-service to be comfortable. We need to shift people to these alternative payment models. So that continues to be a challenge and a potential opportunity. We've talked about CARES Act funding as a one-off, but there'll be some of the advanced funding from CMF will need to be returned. as well. So really presents a challenging environment. Here you see a graphic outlining the Kaiser Family Foundation comment around family coverage exceeding $20,000 annually. It's really quite extraordinary in terms of what those costs look like. And we talk about disruption and change, and you have some incredibly well-capitalized new entrants entering the market. Amazon Care is being something that is going to be a factor for many markets, and they're looking to expand that and roll that out. In many rural markets, Walmart is a presence already, and clearly a part of their strategy is to continue to expand their healthcare footprint. So they become a competitor for outpatient ancillaries and primary care and urgent care to existing legacy rural health systems. So a potential challenge there. And you can see here, in this case, we're looking at New Hampshire as the light blue line and the US as the dark blue. Excuse me, I've got it backwards. The US is light blue and New Hampshire is dark blue. But you can see that trend line and the decrease in admissions per thousand. What's interesting is if you look to the left, hospital outpatient visits decreasing in 2018 from 2017 levels. Again, that's a new phenomenon. In a lot of health systems, the growth in outpatient was helping to offset the decline in inpatient care. And we can't assume that that's going to continue. Again, part of the backdrop, negative hospital margins. You can see they've been trending up, but even in this case, for rural, inclusive of cause, you see a negative 2% margin on Medicare business overall. So a challenging situation there. And so, you know, one of the things we see as a response to this is hospital closures. And it clearly is incredibly disruptive and concerning. Visually, there clearly is a clustering in states that have not expanded Medicaid, but by no means is this limited to those states. You can see a pretty broad distribution of closures. And by all accounts, that's going to continue. So part of the reaction as well is consolidation and this affiliation trend, and it continues. And a lot of the things I've been talking about really are somewhat of the catalysts behind this. You can see, you know, the financial, operational drivers, the labor costs, rising staffing costs really is a major threat going forward in terms of margin pressure and creating huge operational financial pressures on systems. How do we continue to provide those services, and how do we do it in a way that we're actually financially viable long term? Real challenges there. The last bullet point on the catalyst, the economies of skill, is something that I think is important. We always talk about scale and how important that can be. Healthcare has for baseline operations, especially critical access hospitals, which are often, you know, kind of staffing for low volume already, have a high proportion of fixed costs at the rural affiliate, and that's absolutely true. But what's also true is economies of skill, and what we mean by that is the regulatory environment and the competitive environment and the operating environment require additional levels of expertise just to make sure that you're compliant with all those requirements. And that becomes a rate limiter in some instances as well. So we have a consolidating industry, increasing competition, the operating environment from a payment perspective, from a regulatory perspective, from an operational and cost input perspective is becoming more challenging. We've got demand shifting, inpatient legacy business declining, and increasing competition in the outpatient setting. And national shortages, which are a huge factor in terms of how do you sustain operations and do it in a way that's not going to destroy the financial underpinnings of your health system. So it's a really challenging market, and a really challenging industry. And so for a lot of organizations, absolutely essential. You've got to do the hard work and the essential work of focusing on operations. And frankly, that's true whether you're in a partnership or you're contemplating a partnership or you decide to remain independent. That kind of crosses all of those scenarios. And what I would say is for a rural health system that may be struggling, if you don't have a plan, you're working, and you can show some progress, many potential partners get scared off by that, because one of the scarce resources in healthcare today is frankly the management depth, management time, to help a new affiliate address those issues. So I think one of the messages I would give is that partnering is not a panacea. It has certain inherent risk factors to it, which I'll talk about in just a minute. But it's also not a panacea, because if you're having operational difficulties, if you don't have a plan you're working, and some progress you can show, there's a lot of potential partners out there that would be scared off by that. They don't have the bandwidth to take on a full turnaround. So it's important to do that hard work and essential work as leaders in the organization ourselves. But the other point I want to make about partnering is really important. And it's one of the fundamental takeaways here. It is not a risk-free option. When you either are in an existing partnership or talking about potentially creating one, you are bringing partner risks to the table. And that really entails that your partner is going to do what you thought they were going to do, what they said they were going to do. And it's really important to mitigate that partner risk, but it never goes away. And the mitigation tools that we use on behalf of our clients are selecting a strategically aligned partner, really vetting that partner, making sure you have the right structure for your needs and constraints and objectives, and having contractually enforceable terms. Those are all essential. And you can't eliminate partner risk, which is why I say it's not a risk-free option, but you can do your homework and mitigate those items. So part of that is making sure you do your homework to evaluate partners, that their track record matches what they're telling you, that they walk the talk in essence. So value levers for rural health systems. What do we mean when we say that? Many of these items are things that you're familiar with. Our experience is that many rural health systems have upside opportunity around some or many of these. And so really examining these and understanding, have we optimized them is job one, as part of that operational tune-up, if you will, for rural health system leadership. What I can tell you is, even at the prospective partner level, even with administrators that have come out of the rural setting, and maybe they worked in a CA or a rural health system 5 years ago or 10 years ago, they're far enough removed at this point where, even though they might understand cost-based payment and some of these other value drivers, they're no longer really asking the right questions. And that's been our experience, where we've seen former critical access hospital executives advance into a large system and take on a different role. And when they're looking at rural affiliates, really not asking the right questions. And part of that is from their perspective has shifted, but part of that is they're removed from the day-to-day expertise and focus on these things. So, but each of these really present opportunities to improve operations, but also opportunities that potentially convey value. So it's essential that you be able to quantify them and communicate them with an existing or prospective partner. I will say, the home office allocation, we have a partner of ours who was part of a system. And even though our client was saying to the system, there's a huge potential pickup here, and the system's own auditors were saying, hey, there's a huge potential pickup here, the CFO at the system was not comfortable with it. He couldn't wrap his arms around it. And so even though they were a member of this system and qualified for a home office allocation to their cost report, which would have enhanced payment, the system never took advantage of that. And sadly, there are situations like that that occur time and time again. So it's essential that we do the homework and look at the value potential of these various components, and make sure, either if you're talking to a prospective partner, understand how they've approached this at their affiliates. If you're talking about an existing partnership, and we'll talk about this in a minute, identify an early win, something that has a low cost barrier to it, but that can demonstrate the value as a way to start the dialogue. Take that early progress, that early win, and then see if you can expand and look at other value levers as a way to enhance your partner's appreciation and understanding of the value that you bring. So really two different approaches here. For prospective partners, i.e. you're talking about a partner, what we want to make sure that you do is you vet the partners, you do the due diligence, and they're strategically aligned and have shown a track record of enhancing the value and committing and investing in their rural affiliates. You want a structure that fits your objectives. So if all you need is access to clinical specialists, you've got a robust balance sheet, and you can check all the other boxes, then you may not need a full integrated partnership. It might be something that's really has a clinical focus. On the other hand, if one of the key value propositions you need to make everything work is the home office allocation, what's necessary to qualify for that is that the partnership and the partner assume operating control and operating risk, which is a much more control and tighter aligned partnership. What I will say is, even on the types of partnerships that are more tightly aligned, is there's a huge amount of variability even within an existing structure between different potential partners or existing partners. Sole member substitution is the most common not-for-profit to not-for-profit affiliation model, and there's absolutely huge variability in how decisions get made, where the decision rights reside, what kind of reserve powers exist for the local affiliate, the rural affiliate. So really important to do your homework, find the right structure, find the right partner. I mentioned contractually enforceable terms earlier, absolutely essential. And really evaluating, do their strengths and the commitments you can negotiate, are those adequately mitigating your strategic and operating risks? It's really important to make sure those line up. We've spent years unwinding affiliations that have been done by others, where the structure and the partners were not a good fit. They got it wrong, and it can be a huge distraction and hugely costly if you get it wrong. So again, we talked about the track record and doing the due diligence there. For existing partners, making sure the partner understands the value proposition, evaluating the structure. You know, we've had clients of ours where we've helped negotiate a structure, and then they've said, you know, I think we need to do something different than what we initially talked about. And then helping, once you've identified your needs and come up with a new understanding, either because the market's changed or you have a different appreciation for what you need, revising that and updating those relationships, incredibly important. Quantifying the return on investment to reflect your value proposition. Again, essential. Looking for that early, easy win as a way to start that dialogue is really the most important thing. If you go at your existing partner and say, my goodness, there's this tremendous opportunity, but it's going to cost, you know, $500,000 to realize it, you're probably going to be met with some skepticism. Versus if you have an opportunity that has a much lower cost associated with it, and you use that early win, high return on investment to then say, let's look at some other options. You now have the credibility to take a closer lens to a bunch of those drivers of value. So to make this a little more real, we wanted to provide some examples from the field in terms of what we're talking about when we talk about the rural value proposition and making it work. So we had a client that was entering into discussions with a large multi-state health system, and the initial proposal was really very poor. Our client had actually a strong balance sheet, was profitable, was serving a good and growing market. Their big problem for them was they had a facility that was 40, 50 years old and really required significant investment, including potentially a replacement. So the prospective partner looked at them and put together a letter of intent that really was incredibly poor. No commitment of capital, no commitments to services, and very little local participation in governance at all. And we dug into the background, and it was clear that the prospective partner just had a misunderstanding, didn't understand a number of the value drivers, even though this large system had 4 or 5 CAs that they operated. And some of their financial leaders came out of the critical access hospital environment. They were putting a very different value on the home office cost allocation benefit, $100,000 annually, whereas our analysis showed that it was in excess of $3 million annually. So those differences are huge. In this case, this critical access hospital had a very significant share of cost-based payment. Also was a significant benefit if they were going to make an investment in the facility. And modest changes in referrals could have a huge impact on ROI. Again, getting back to that, how much of an incremental referral going back to the regional partner is variable cost versus fixed cost and creates contribution margin. But the end result of this was a much enhanced, vastly different proposal that included capital commitments to services, and significant role and reserve powers related to governance and major decisions. So that's one example of what we've seen. Another example is another critical access hospital talking to, in another state, talking to a regional referral center, and they specifically wanted to zero in on, in this case, 5 potential value levers, and you can see them here. And so this was kind of our charge. And so what we did was look at those 5 drivers of value and quantify them in this case, and really went from what are the opportunities that the 2 organizations could realize independently, and pretty modest, although not insignificant in terms of what they could do to enhance the swing bed program performance at the CA. And then a more limited partnership that might be more clinically driven and around managing some volumes. And you can see, again, that's 1.3 million annually. Again, that's not insignificant. A full affiliation that would give access to the home office allocation, conservative estimate of that value in this case, about 2 million annually. And you start to see the full value of what an affiliation could bring just across those 4 or 5 value levers of about 3.6 million annually. And both organizations really thought that was incredibly helpful in their dialogue and helping to create interest to continue that dialogue and pursue a partnership. Obviously, as I've mentioned previously, the home office allocation to tap into that would require a much more aligned model than something that might be just a clinical partnership, et cetera. So we've covered a lot of ground. How do we capture that value with existing partners? Well, it's important, as we said, to find the win-win. It's got to be worthwhile and of value to your existing partner. And you've got to do your homework to quantify the opportunities. You don't want to overstate the value, to overpromise and underdeliver, because again, if you're doing this right, hopefully it's the start of a process where you're you're educating and informing your partner and working with them collaboratively to unleash some of that value. But finding an early win, something that has a lower cost of entry, but a high ROI and maybe a quicker time to realize that ROI is essential. So cost to implement is a factor. The timing and magnitude of the return on investment is important. And the ability and ease of execution also important. Wanting to make sure that it creates value for both the partner and the rural affiliate, and that it also is strategically aligned. So you don't want to be proposing something that is counter to some major new strategic initiative at your partner, and want to be attuned to that. I think if you can do those things, find that early win that matches those things, I think it can create a very rich collaboration and dialogue that will help to unleash that value. So that would be our suggestion and the approach for existing partnerships. And to be clear, our experience is, well-run, sophisticated systems often miss these rural attributes because they don't live that day to day. They don't walk in your shoes. So don't take for granted that they understand, because they're really focused elsewhere. Now, for prospective partners, if you are independent, but you've decided finding a partner could really help mitigate some of the strategic risks and help us achieve our objectives and sustain our mission, what are some of the approaches? Number one is I would never have an exclusive conversation with only one partner, because you want to be able to gather information. Your board, who are functioning as fiduciaries, want to be able at the end of the day to say, we've looked at our options, we've carefully evaluated it, and this is the best option for us and this community. And so having folks compete and being able to weigh competing proposals side by side is really important. Using the process and the time to gather information, assemble information, so that, again, your board and your leadership team have the information they need to make an informed decision. You want to use the process to educate partners as to your value. So again, part of this is, just as we gave in some of those case studies, the opportunity to share, hey, I think you guys are leaving this out or undervaluing this potential lever that really can create value for both of us. You need to assess whether a partner is willing to adjust terms and whether they're just willing to engage around it. Sadly, we have had prospective partners that just are unable to wrap their arms around the value proposition and just can't quite get there. And that's why it's important to talk to more than one partner. An example in the Northeast, we had a critical access client that had an obvious partner. It was their referral partner in the region, but that referral partner just could not or would not understand what a critical access hospital brought to their system. And happily for them, they were able to find another partner that was very comfortable with rural affiliates and understood and appreciated the value they brought. So that's an important part of that. Leveraging those analyses, leveraging that information, using that as part of a competitive process. Evaluating partners' track record. Again, does their walk match their talk? Absolutely essential. And lastly, one of the mistakes we see is organizations having a obvious partner, somebody they worked with well clinically, and signing a letter of intent, which is non-binding, but typically has an exclusive period to it, but that doesn't have any deal terms associated with it. So essentially what you've done is you've tied yourself to an exclusive negotiation without actually having any understanding of what the affiliation or partnership terms are going to look like. And that creates a lot of negotiating power for the people you've just given an exclusive to. Our advice to anybody would be, do not give an exclusive right to anybody until you've got a set of terms that meet your objectives and meet your needs. At that point, there's a necessity to go exclusive because you need to do the hard work and the heavy lifting to take a letter of intent and make it a binding agreement and doing the due diligence, et cetera. If it's a looser contractual affiliation, the obligations on the due diligence and legal side are less, but there are also important hurdles you need to be mindful of. If it's not a risk sharing arrangement, i.e. operating risk is present in it, you have to be very careful about getting into anti-competitive types of situations. So key takeaways, and I think we're doing okay time-wise. The significant and intrinsic value of rural health systems is often missed or undervalued by both existing and prospective partners. So we've seen it time and time again, and sadly, it is the minority of prospective and existing partners that have actually unleashed and accessed that value in our experience. It's really important if you're in a partnership or you're thinking about a partnership to know your value, do your homework, and ideally engage with partners if you're looking at prospective partnerships, so you're not having an exclusive conversation before you've negotiated key deal terms. And for existing partners, that you're approaching them and finding that early win or that early win-win, and then using that as the start of a more robust conversation to unleash that value. One thing I touched on earlier, if operating results are really challenging, it can be difficult to have this conversation. And frankly, the frame of reference needs to be, we're going to focus on operations and improving operations. And a key component of that can be unleashing these components of value. But any prospective partner or existing partner is going to become focused on how do we address operations. And I think one of the challenges is if you're in an existing partnership and financial results and operating results are poor, the natural bias is, at the system partner level to want to cut your way out of that. And certainly cost management can be an important lever, but I think there tends to be too much focus on that as opposed to where can some of these value levers realize improved operating performance. But it is going to color the conversations. So job one is really having a plan on the operational performance. But it's essential that you're able to explain and quantify your value to partners, whether they're existing or prospective, and really focusing on sustainable win-wins. So some of that is common sense. I guess the major insight I would share in summation is that it's not an easy conversation to have, and it certainly is one where I would not assume that either a prospective partner or an existing partner understands your value proposition. Again, our experience is most large, sophisticated systems, because this is fairly esoteric and not central to maybe the top 3 priorities they face in any given year, they don't really understand it. And that same thing occurs if you're talking to prospective partners. I can guarantee you that not all of them will understand the unique aspects of the rural value proposition. So really just want to, first of all, thank everyone for their time today and open it up for any questions or discussion. Thank you all very much.
That was excellent, Jeff. Thank you, sir. And to our audience, please feel free to use the chat if you have any questions, or if you take yourself off mute, if there's anything you wanted to gain additional clarification on. I believe it's *6 for anyone who called in. Lot of excellent information today, Jeff. Thank you so much, sir. I really liked your value lever slide, because there's so many things that we in a Delta program we work through, and we all have 340B on our mind, and we all have swing bed on our mind, and we all have this expansion of service lines and trying to increase market capture and minimize out migrations and all of those things. But, like your case study to include home office cost allocation. I mean, like that was very informative and certainly, additional things that we could all be considered. So good stuff there. And, I also really, really liked how you frame this in a way where, the ball is in our court when it comes to this being competitive and really having the advantage of all of these, from covered lives to everything that rural does have as a selling point to for multiple proposals of who potentially we could be working with. I really liked how you articulated to make sure we're getting aligning our partners with the strategic value direction our organization is headed, and making sure it's a really exceptional fit and the right opportunity before we actually get into exclusive letters of intent. And even still, if we get to that point, make sure it's contractually enforceable. Even, because situations can and often do change. 5-10 years from now may look vastly different, and really looking downrange to make sure that affiliation is co-witness to where our values of our organization lies is critical. So
Nick, you obviously want to have a partner that you like and trust, and you've got good alignment with. But the reality is that senior leaders, they retire, they leave for other jobs, and the same thing's true with board leadership. And so it's, you can't eliminate all risk, but even though you may have an understanding, if it's not backed up with something in writing that's contractually enforceable, you've put your community and your organization at risk. And, I refer to them casually as weasel words, and we want to get the weasel words out of an agreement. And so when somebody says, we'll commit to invest up to, $10 million. Well, if you dissect that word as a layperson and actually get into it, that means they could satisfy that contractual term by investing anywhere from 0 to the maximum amount. So effectively, they've given themselves a tremendous out. And people will often focus on the bigger number, not recognizing that, my gosh, what they've just put in there means that they actually have no real commitment to invest in our community. Those are obviously key areas, and certainly there are probably 8 to 10 areas that are really important to focus on. I'll give you another example, and this is one where a client didn't listen to our advice. But we often will say, if somebody's got a healthy balance sheet, that it's really important to say, as part of any affiliation or partnership, that access to those funds lies with our board. And if you want to access those, our board needs to approve it. And frankly, we're not spending the reserves we've built up over the years on things outside of our community unless there's some pro rata system tax that's in place. So if they want to put in a system-wide IT system, we'll pay our share of that, but we're not going to pay more than our share of that. And we had a client that essentially provided a system partner with unfettered access to the non-designated board funds, which were significant in this case. And I just thought that was an overreach by their partner and inappropriate, but I thought a miss from the local perspective in terms of protecting a community asset.
Excellent example there. That to speak to your point, we have even our high performance systems that have agreements in place that have been historically successful. Doesn't necessarily mean that there's not a margin to continue to refine that. What does that mean now? Do we need to renegotiate terms? Is this going to continue to work for us? And I do feel extremely privileged that across the Delta, we do have the capability to assist in feasibilities and any other kind of analysis of potential systems partnership. And we have a very unique opportunity here through this program to even get a third party, even for those of you out there who have an exceptional team that can do this internally. We have an ability to really bring third party in to assist and just taking another look at it and helping you really make sure it's a ideal fit. You know, one of the things that you mentioned that I also thought was being this kind of exceptional stewards of the funds. We came off of all of this, you know, COVID stimulus, so much funding that was in reality being told to spend down, you know, and having this kind of liquidity available, and but you know, really being exceptional stewards of that, and making sure it's being leveraged in the most optimal way for what's going to help us further down the line as we continue to transition through value. So but really being exceptional stewards with that as well, I thought was an excellent point. And let me while I'm kind of rambling here, let me check our chat box to see if we have any questions. And we have just a couple minutes left. I don't know if any of our audience does have anything else they'd like to add or ask, but please feel free to join. And
I would just say, Nick, in response to your comment that, you know, you're right. There's this additional liquidity, and this gets back to the operational focus. You know, folks, an independent strategy, and most of our work as a firm, and I know, you know, most of the work you do is let's focus on operations so folks can be viable as independent organizations, and you can kind of pick and choose. Do you have a clinical kind of a partnership? If you don't necessarily need the full bore partner, and that's a very reasonable, viable, prudent strategy with the right circumstances. But it's really important to understand what the underlying run rate is of the organization in terms of how quickly you'll burn through the liquidity you've got now, and you know, the challenging environment going forward. So I think that, you know, really good exercise to look at, you know, how long will this cash last at current run rate, and what do we need to do to make that sustainable long term. That is fundamental to kind of remaining sustainable as an independent organization, and is a great outcome if you can get there, for sure. And again, I would just emphasize, you know, partnering is not a risk-free endeavor. It has an inherent risk profile to it. So I certainly never want anybody to come away from one of my talks thinking, oh, this guy's telling us to partner, because I'm really not. I want folks to evaluate the risks and select the best option for their community and their organization. And that may very well mean remaining independent and just maybe selectively accessing needed clinical or other services on a really more tactical and basis than a kind of a big strategic partnership.
you know, that's actually excellent segue. What you just said, we have Mr. Kramer ask a question here in the chat. We got, is the acquisition interest falling in favor of contractual affiliations or management agreements? Is that kind of the trend you're seeing? Or,
you know, I think it's too early to say. I think there's competing forces at work here. So we know that the feds are taking a more critical eye of acquisitions and the like, the more aligned affiliations, that there's a more scrutiny of those. And we know that many partners are more discerning because they want somebody that's geographically coherent with where their service is, and they are concerned about taking on something that may require significant resources. So those are all things that would suggest less interest in kind of the acquisition model. The counterweight to that is that in many markets, not all, what's needed most is kind of the operational and clinical alignment and resources. And it can be very difficult to get at adequate access to those without a tighter alignment, because there's a lot of competing demands on those resources. So it's very situation specific, very market specific. And I think each of those structures has pros and cons to them. And so, one of the things that's really important is finding that structure that matches the needs and objectives of the organizations and will mitigate its risks, its risk profile. And that might be a management agreement or a clinical affiliation in some instances. In other instances, it might mean something that's more integrated and a tighter affiliation in others. So very situation specific. And I think the market's in a bit of flux right now in terms of trends that we see, to be clear.
Thank you so much for that, Jeff. And we actually, let's see, we'll check our time here. Okay, we got about 3 minutes left, and I believe Caleb has a poll for us. And while we're closing out with a poll here, I have one last question for you, Jeff. What would you say are the top rural hospital attributes that you cut for today that really are overlooked by the larger health systems that we potentially would be considered to affiliate with?
I probably would start with cost-based payment and the cost report, which are just so fundamental and flow into so many different areas. So that's one. A second was an example I gave where I think it's very easy to get the economics of what is the value of a rural affiliate and their attributed lives and an incremental referral wrong. So that would be two. And the third would be that collection of designations, whether it's rural health clinics, and how you set up those with within your rural operations where you can optimize payment, et cetera. So I would say getting the designations right, and then operationalizing that, getting the accounting right, if you will, and the economics right on how you value an incremental referral if you're in that partnership or you're talking to a partner. And then lastly, the cost report and cost-based reimbursement, inclusive of the overhead allocation, but also looking at other things. We had a client of ours, Critical Access Hospital, that had $500,000 in standby and provider time in their ED that was not being captured adequately, and there was $500,000 of cost-based reimbursement annually they were missing out on because of their approach to the standby provider time in their ED. So those are examples of ones that I would suggest.
That's great, Jeff. Thank you so much. And we as we're wrapping up here for our audience today, please feel free to come back to this webinar. We'll have it as part of our resource library here at the center. And thank you all so much for carving out time to be with us today. Thank you, Jeff, for sharing your insight and perspective and recommendations on this very, very important topic. So we don't have any other questions left here. All right. Thank you all so much. We greatly appreciate you, and we'll give you time back this afternoon.
Thank you.
Thank you. Have a great afternoon, everyone.